fidelity, and veracity, which is essentially tell the truth. We'll cover the 13 principles of effective treatment that NIDA has laid out, the National Institute of Drug Abuse. Talk a little bit about the professional code of ethics, and there are a variety of them, and ethical responsibilities around the codes of ethics, client rights, mandatory reporting, boundary issues, and using supervision. Sometimes I go off on tangents. So if I get into an area though that you have questions about, where I'm not clear or anything else, just type in your question, and Kate can interrupt me, or I'll stop if I see the question and try and answer it. I'm also going to try and leave a little time at the end just to allow for questions. Just some of the general vocabulary that's often used. I think it's pretty straightforward here. Scope of practice obviously refers to your scope of expertise or your license restrictions in terms of what you're able to do and practice if you have a license. So just quickly a little bit about what effective treatment consists of. These are principles from NIDA. I would also point you to the recent Surgeon General's report that came out, I think, almost 2 weeks ago. That was I believe it was the first report on addictions from the Surgeon General in 50 years. I could be wrong about that. But if you haven't had a chance to see it yet, look that up. The Surgeon General does a nice job of sort of redefining or defining in current terms what addiction is, the neurological components of it, the behavioral components of it, and also spells out in a nice framework where addiction treatment should probably go in the future with respect to integration and working with primary care and mental health care and those other areas of healthcare. But these principles that are laid out here, I think it's 1 through 13, if I'm not mistaken, are from NIDA. I think last year it looks like. So these are fairly recent. I think they reflect the general principles of effective treatment. And just go along here, see if there's anything I want to comment on. I think number 10, detoxification. Well, detoxification is a component of treatment, certainly. If you are familiar with ASAM or work in a state where detoxification is a service that's offered, oftentimes that has been a service where people were detoxified and then immediately released from the program or the service. What Minnesota is working towards now is a reform of that level of care to withdrawal management in line with ASAM, so that there's more than just detoxification. It involves a broader array of service delivery, mental health services, peer support, things of that nature, so that this becomes detoxification and withdrawal management become an actual component of healthcare rather than some separate, a standalone facility or some standalone kind of program. The need to integrate detoxification into the wider realm of healthcare is, to me, one of the critical ways to capture people who are in immediate need, capture them in a nice way, and get them involved or engaged in the healthcare system. And the last 3, I guess, let me see. Yeah, so I'm okay with these, I think, in general principle. We'll talk a little bit about vocabulary, more so about professional and ethical responsibilities. Values, morals, and perspectives, more or less just a quick definition, and the distinction between legal and ethical dilemmas. I will talk in some depth about 42 CFR Part 2, which is the federal privacy law that applies to addiction treatment programs that receive any federal dollars. The reason I'm going to talk about that privacy law is there are some ethical dilemmas that can arise by conforming to the law or following the law that might be challenging for some clinicians to come to terms with, but I'll try and help you as we go through this, try and help you think through how to conceptualize these dilemmas so that when they do occur, and they will, or many of you have probably already experienced some of these conflicts, you'll have at least a sense of how to deal with them. Again, a scope of practice more defined is oftentimes a set of counseling theories that you're familiar with. I would suggest not trying to use theories that you're only, you had one workshop on 2 years ago. Try and use theories that you're familiar with, that you've studied, that you feel competent in or are competent in. Screening, assessment, and diagnosis in scope of practice can apply to the particular your area of expertise and where you would be diagnosing or developing. What do they call those? When it's not an actual diagnosis, but a preliminary diagnosis that you would have maybe a physician sign off on or somebody with a higher credential sign off on. Screening, assessment, and diagnosis are a changing area of this field in that screening and assessments are becoming more global, more comprehensive. They look at the whole person if they're done well and consider social determinants of health. They consider other healthcare issues like mental health problems and physical health problems and all of those things that contribute to the person's health. ASAM, again, I'm not trying to put in a plug for ASAM, but it does focus on a comprehensive set of dimensions for health, and I think that's the direction that most programs are going. Individual, group, and family counseling, again, it's what you're competent in, trained in, and community education, same thing. So it's looking at all these different areas of practice and saying, what am I competent in, and trying to operate within that sort of general realm. Just a quick comparison here between ethical kinds of dilemmas and legal kinds of dilemmas. As you might imagine, legal dilemmas are usually more clear cut. There's pretty clear boundaries around what you can and can't do. Ethical dilemmas are oftentimes more subjective, and you don't always know. You can't always tell on the surface whether a decision is right or wrong because of the complex circumstances that people can present with. So the same applies to legal dilemmas, but not so much. They're more specified, and you're more able to oftentimes determine which way should I go. Not so much with ethical dilemmas that are not clearly defined in the law, or that might vary from state to state too, which is another complication. This duty to warn slide has to do with, it uses TerraSoft versus Regents in California as an example. This was a duty to warn decision that the California Supreme Court made. And actually, it was in 1974, the court determined that mental health professionals in California had a duty to warn someone if their patient was posing a threat to that person. So if your patient was directly threatening someone, you had a duty to warn that person. In 1976, the law was amended, and California stated in the law that clinicians or practitioners had a duty to protect the person that's being threatened. That loosely translates to if your patient, say, was threatening someone directly and there was a specific threat made, that you had a duty to protect the person being threatened by use of reasonable kinds of actions. So that would mean calling the person directly and saying so-and-so has made a threat against you, calling the police, or something that would reasonably be seen as an effort to protect the person that was being threatened. Now, again, state laws might vary on this. This is an example, though, of where duty to warn was used in TerraSoft versus Regents, where I believe the psychiatrist, I could be wrong about this, but I believe the psychiatrist that was involved in this case did not warn someone of an imminent kind of threat, and that person, due to confidentiality, and that person was harmed or killed. Again, I would check your state laws around duty to warn. I know here in Minnesota, Substance abuse counselors, or they're called licensed alcohol and drug abuse counselors here in Minnesota, were not included. I'm sorry, they were included, but practicum students and interns were not covered by this law. So I believe we passed last legislative session the inclusion of interns and practicum students, or students. It's kind of the same thing, I guess. There's something to be aware of. Duty to warn, look it up in your state and see what the requirements are for your particular license or practice, and your agency's policies. So in general, just be good, do good, and above all, do no harm. It's kind of, I hope, obvious to everyone. Responsibilities. So there are several codes of ethics. You have NADAC Code of Ethics. You have National Association of Social Workers. A variety of codes of ethics. Usually they're fairly similar. I think the ICNRC has a code of ethics as well. But pay attention to the ones that apply to you, and become at least familiar with them, so you know what's expected of you in terms of ethical decision making. But like I said, most of them are pretty similar. You have to adhere to all federal and state laws. In the case of confidentiality law, the federal law supersedes state law. I'll get into that more. And then try and interpret and apply the information to your practice. Number 4 is important, not just because it's important to recognize the differences of others, but it also has I think, an implication for cultural differences. Ethical decisions come into play oftentimes when you're working with people of other cultures whose definition of illness and their definition of wellness may be much different than your own. Therefore, their solutions to problems may pose ethical dilemmas, in the sense that whatever practice their culture might believe in or follow may go against certain state laws or federal laws. I'm not thinking of an example offhand, but let's just think in terms of with some Native American communities who may want to use ceremonial tobacco in a treatment setting, and would that conflict with your agency's policies, state law, federal law, probably state law? How would you manage those kinds of dilemmas when someone wants to practice a cultural a ceremony or a tradition because they believe it's a part of health and wellness, and your restrictions say that no, you can't do that? How do you manage or manipulate that kind of situation to benefit both and stay within the law and the agency's policies? Always utilize supervisors. That's what they're for. If you're a supervisor, you should have probably have dealt with various kinds of situations before, and probably can offer good guidance on how to move forward. If you're a clinician, it's always good, I think, even if you're pretty sure what direction to go with an ethical concern, it's always good to run it by a supervisor. At least then there's two of you thinking about it, and you either get somebody to affirm what you've already thought, or they may come up with other things to think about for you. So I know most people have to get ethics CEUs as a part of their license. So I know everyone has to attend trainings like this one. I would just say, if you're in a training, this one included, where you want to get more in depth about a particular kind of ethical dilemma, that you use these opportunities to do that. And let's see. The last one's important. I think it's the last one. Maintain your own physical and mental health. As a professional, we often don't take care of ourselves as well as we take care of our clients. And it's important, it may be obvious, but it's important to think about that, and maybe again, using supervision, it's a way to sort of check in with your supervisor and let them know how you're doing. If you need a break, uh, if you feel like your work's affected by caseloads and stress levels and things of that nature. But please take care of yourself, or we can't help the people that we went into this for to help. Here's an example of the NADAC Code of Ethics. You can Google it. I don't think you need the link here, but again, that's just one of many. These are more or less headings for what a code of ethics might consist of. So I won't spend too much time on this, but the obvious things that I think all people know about are, don't have dual relationships with your clients. Don't hire them to do work for you. Don't have a romantic relationship with them. Adhere to privacy law. Stay within your scope of practice, etc. I mean, I think these are pretty clear. If you do have questions about any of these things, just shoot a question to me and Kate. It depends on where you work as to whether or not agencies forbid you to disclose that you're in recovery. I'll just give you a quick rationale for either decision. It can be challenging for someone that, well, it can be challenging for in either case, but for agencies that say, no, I don't want you to reveal that you're in recovery, the reason for that often is that they don't want to have a situation where some staff are viewed as more knowledgeable than others by virtue of their lived experience. So the idea there is not to staff split, not to have clients gravitate towards one counselor versus another just because of their personal background. What I found in practice is that if you do not tell clients whether or not you're in recovery, if you say it's our policy that we don't reveal that kind of information about ourselves, usually the client has no idea. They might think they know whether you're in recovery or not, but they often don't. My personal belief around that is that clinicians in recovery have a set of, again, lived experience that can be very useful in the counseling relationship, but they can also be sort of subjective, and they can be sort of already biased a little bit towards one way of thinking, whereas counselors without a recovery background can be more objective oftentimes. They don't have that personal bias issue, and they may not have that personal lived experience, but they have to develop other counseling skills to to work with this population to begin with. So my personal belief, and this is just my personal belief, is that there's a place and a time for both. But usually you have to follow your agency's policies around this. So that's why it's not consistent from, program to program or state to state. I think we're moving in a direction where it's probably more acceptable to reveal that you're in recovery, but at the same time, that has to be done with some finesse so that other clinicians aren't singled out as not being as proficient. I think that's fair to say. All agencies have mandatory reporting policies. You'll just want to be familiar with them. Acceptable practices, same thing. Sometimes you might find yourself in a position where you have to report a colleague for some sort of ethical violation. That's something, of course, you'd want to discuss with your supervisor first. But it does happen, not often, but it does happen. And it would be, again, something I think the supervisor and you could work out in terms of whether this was a situation that required some sort of complaint, either filed with the licensing board or some other state agency. I understand the dilemma there is reporting a colleague. At the same time, our primary concern is with the client's well-being. So if somebody does something that you feel is a flagrant violation of an ethical law or somehow negatively impacts clients to the extent that you think they need to be reported, then discuss with your supervisor. There's a link here to an example of an ethics violation form that Iowa uses. So if you want to look that up and just get a sense of that, I think most states are, I won't say this for certain, but I think most states have similar kinds of processes. Client rights. Of course, we don't want to discriminate. Confidentiality, as we'll talk about in a bit. Informed consent, I'll skip to that. Informed consent is when you inform the client of all available treatment options. So if you work in a program where only a certain philosophy is followed or only certain kinds of services are offered, it's your responsibility as a clinician to make sure the client's aware of all options available to them, whether it's in your program or somewhere else in the community that they could take advantage of for help. An example of that would be something like medication-assisted therapy. If you work in a program that, say, is abstinence-based, there are fewer and fewer of those, but if you work in one like that, and someone comes in with an opioid disorder, or have a heroin problem, something of that nature, ethically you have to make them aware of medication-assisted therapy options in the community, even if you don't offer that at your particular agencies. That's just an example, but it's that kind of sort of transparency that you want to provide, saying to the client, these kinds of things are out there. Here's what we offer, and here's our philosophy on care. I hope that made sense. I'm just trying to think if there's anything I need to sort of embellish on here. Again, I would go back to just cultural differences. You can't be proficient in all cultures, but it's helpful, I think, to try and understand why somebody might be thinking or believing a certain way about health, and what might be your role in including those beliefs in your intervention. So thinking in terms of how that culture views health and wellness and illness, and then trying to apply that to how you respond and interact with that person. I know that's kind of vague, but and obviously you don't want to discriminate based on gender or race or anything of that nature. I'm just thinking in terms of unintentional kinds of discrimination where a particular, like say, Western model of medicine is followed when it may not apply to a particular culture in their views of health and wellness. So I guess be mindful of that, and be as knowledgeable as you can about how to deal with cultural differences. Use your supervisor for that kind of assistance as well, if you're not familiar with a way to work with a broad array of people with different belief systems, different than your own. So I keep saying we're going to get to 42 CFR. We will. Just a second. Oh, there it is. All right. So if you're not familiar with this law, you probably should be. 42 Code of Federal Regulations, Part 2, is a federal privacy law that applies only to addiction treatment programs and only those that receive federal dollars, which is most public health, public community-based treatment programs. It's a privacy law that's more restrictive than HIPAA. There are some exceptions to revealing information about client information, but you should know the basics of the law just so you, when you run into situations that might throw you for a loop, you kind of have some sense of where to go with it. Let me see what the next slide says real quick. This is the premise of the law here, in that you can't release any client information, including the client's presence in your facility, to anyone including law enforcement, without the written consent of the client. Again, there are some exceptions that I'll get into, but that's the basis of the law. It was written back in the early 70s to protect clients who came to substance abuse treatment or substance use disorder treatment, who maybe had legal or employment or other kinds of ties that might be in jeopardy if it was discovered that they were in addiction treatment. So the law was put into place to protect those people, believing that if there wasn't a law to protect them, they would never go to treatment because they could be discovered by law enforcement, or they could be discovered by probation or their employer, and might lose their jobs. They might get into additional legal trouble. So the law was put into place to make sure that people had a safe place to go to get help for addictions without the fear of being discovered. It was written a long time ago, so there are revisions to this law that are being proposed right now through SAMHSA that would allow for some changes to the law that would make electronic communications easier. The purpose being, or the intention being, to help with the sharing of electronic records with primary care providers, mental health providers, and have that aspect of integration actually occur with respect to healthcare. If you have these privacy laws in place for addiction clients in addiction treatment, it's difficult to share records if they're not willing to sign a consent form. In fact, it's impossible to. So it can really hinder their care, and that was the intention of revising the law. Now, I haven't seen the final revisions, but I do know that if they're not passed by the end of this month or December, that SAMHSA and that the government team that's working on this will have to start from scratch. There's some sort of time limit in terms of when they can get these revisions passed. So we'll see what happens with that. For now, you have to follow the law as it's written. You can find it by Googling 42 CFR Part 2, and there's an electronic version of the law. You can look through it and see what the full extent of the law says. I'll go through the high notes here, try to hit the high notes, so that you have a good sense of what it means and why it can pose an ethical dilemma at times. And this is an example. I'm going to go back just a second. So the exceptions to the law. One is if there's a medical emergency. If somebody's having a heart attack in your facility, yes, you can contact paramedics. You can only give them the information they need to treat the person. So you don't want to give them everything about the client, but you want to give them whatever information they need to treat the client. Child abuse is a reportable offense. And a exception to the law, or not an exception, but a way that you can provide client information without consent. Of course, written consent is a way that you can release information. And the other way is, there's two more actually. Another way is if somebody commits a crime on the program premises. So if somebody commits an assault, they steal property, they damage property, you can report that without the client's consent to the police. Again, you can only give them information that they need, but those kinds of things are reportable without consent. The last thing is if there's a court order, a specific court order and a subpoena that accompanies this court order, then you're compelled to release information to the courts. A subpoena by itself or a court order by itself does not compel you to release any information, even if it's signed by a judge. Search warrants are not a reason to release any information. So here's the dilemma. Excuse me. Here's a dilemma that can come up for many programs. You have a police officer. I'll give you an example, a real life one. I used to manage a large withdrawal management program here in St. Paul. And one day, the Violent Crimes Division, about 6 big guys with guns, came in to our program, and they came to my office and said, we know so-and-so is in your facility, and they're wanted for questioning around a murder investigation, and we need to talk with this person. And they didn't have any paperwork. They just gave me the person's name, and I said, what you would expect to say. I said, I can't confirm or deny that that person is here, which raised some eyebrows with these guys. But I explained the law to them in that I was required to withhold any client information, including their presence in the facility, without a specific court order and a subpoena signed by a judge. And I helped them with the process of how to get that with our county attorney. They left, they staked out the building, but they left without knowing whether that person was there or not. Got the court order, got the subpoena, and came back with the proper documents. And I then led the client to a private room, and they talked to him there. But the point is, you oftentimes have law enforcement show up with search warrants, show up with just a subpoena, show up with just a court order, and they say we demand these records, or we demand to see this person. And you actually cannot reveal anything about that person, even to law enforcement, without the proper documents, which are a court order and a subpoena. In the electronic version of the law, if you look it up, it specifies what the court order must consist of and what the subpoena must consist of. The subpoena is what compels you to release information. The court order allows you to, but you're not compelled to. It can really be intimidating if you have police showing up or judges calling you, demanding this kind of information. But I've never had a situation where, once I've explained the law and provided the law to the law enforcement officer or the judge, I've never had a situation where they've come back and argued further. They recognize that within this law, it prohibits you from releasing information unless they meet one of the exceptions that I mentioned. So it can be a dilemma for staff as well, an ethical dilemma, because the other side of that coin was we had someone in our facility who was wanted for questioning in a murder. Now, whether that person was dangerous or not, I don't know, but it does pose the question then, what do I tell the staff to take reasonable precautions so that they're safe? And that was the flip side of the equation. So in my case, I didn't tell the staff what the person was wanted for. I did say that there was some reason to believe the person could be dangerous, not to sort of use a lot of hyperbole, but to at least make staff aware. Let's just keep an eye on him. Don't do anything differently, but keep an eye on him. I felt that was a reasonable kind of precaution to take. I didn't want this person doing anything to hurt our staff or other clients. And at the same time, I didn't want to reveal too much about what they were being wanted for, primarily because I didn't want to create a situation out of that where staff were too obvious about their concerns, and that could lead to its own set of problems. But anyway, that's an example of where this law could come into play and why you should be familiar with it. If your state has privacy laws that are less restrictive, you have to go with the more restrictive law always. So if you're looking at HIPAA, 42 CFR, and some state privacy law, and they all sort of conflict or have different kinds of restrictions, you always have to go with the more restrictive law. And this would probably be it. So there you go. This was just an example of a ethical dilemma that you might face with respect to privacy. I'll give you a second to read it. Okay, so the answer is B. When you do have requests for information, even if you have a consent form, only give the information that's being requested, and only give the information that you feel is relevant to what it's being asked for. You have the ability to restrict the information that's given based on what you think would be best for the client. So even if there's a consent form in place, it doesn't mean that you have to release that information. It means you're allowed to by law. So, if there's information they're requesting that isn't relevant in any way to what the purpose of the consent is for, then you have to decide and talk with the supervisor. Should I release this information or should I not? But keep that in mind that just because there's a consent form doesn't mean you have to release the information. You should also use the consent form structure that's in 42 CFR Part 2. They provide a template, and it should have the consent form should have all of the components that are required under this law in the form itself. So make sure you look that up at some point. If your agency isn't following this, you might want to bring it to someone's attention. It's the same thing. That was the answer. Hey, I got it right. Again, you have to follow agency policies. You have to follow state laws, federal laws, ethical guidelines. Use each other and use your supervisors. That's my best advice there. And report on ethical behavior if it's deemed appropriate by you and your supervisor. You know, ongoing education can be sort of a hassle. You have to get all these CEUs before you get your license renewed. Again, try and use these kinds of these webinars or workshops as an opportunity to ask more difficult questions, more real life examples of what you might have faced, or try and gain knowledge from these workshops beyond the obvious kinds of things that you see in them, because it's not always it's easy to say do good, do no harm, do the right thing, but it's much more complicated in real life situations to know when that's which is which. It intuitively it wouldn't seem that way, but there's those of you who've worked in this profession, the helping profession, for a while, it's not always black and white. These are just definitions of the terms I think we mentioned early on in the webinar. So I don't think there's anything here other than maybe fidelity I didn't mention. Fidelity and honesty. Well, fidelity is, to me, it's treating clients with an equal kind of response. So you treat whether you like someone or don't like them personally, that you still treat them equally, give them the same, afford them the same kinds of care that anyone else would get. You start showing favoritism to a client simply because they're very personable and likable, you can get yourself into trouble in a hurry. So I had a boss one time that gave me some good advice. He said, the people that are the most difficult, the most obnoxious, the hardest to work with are the people that need our help the most. And that's always helped me to sort of get my moral compass in line and realize that it doesn't matter whether or not I like somebody or whether or not I think they're telling the truth. I still have to treat them the same as I would anybody else, and try and help them to the same extent that I would anybody else. Are there any questions? I should stop for a second. Sometimes that federal law will bring up questions, so I'll just wait a second and see if there are.
Thanks, Bob. We did have one ethical situation come in already, but I want to encourage others. The Q&A pod is just to the right of the presentation, and the field to type in your question is at the bottom of that pod. So please submit any questions that you have, and so we'll get started with this ethical situation that Susan submitted. So she says, this occurred at our facility when a client tested positive for HIV/AIDS and had been diagnosed by a doctor with this condition. A person in an AA meeting disclosed privately to a counselor that he was seeing this individual and that they had an intimate relationship which was putting him at risk for contracting HIV and/or AIDS, which can be a life-threatening condition as well. is it appropriate to disclose the client's condition to the second party? Both situations, the client in the facility and the AA meeting, since both are confidentiality based.
Yeah, confidentiality in AA meetings is kind of a um, kind of a handshake agreement. You know, I think you could maybe pursue privacy, but I don't think you'd get anywhere with it. As far as the actual situation goes, um, I don't have all the details, and it's a good question. It really is a good question. I think here's what I would say, and it would require you to talk more with a supervisor about this, but um, I would say if you were in a situation with somebody who tested positive for HIV/AIDS said to you, I'm in an intimate relationship, but I haven't told my partner that I have been diagnosed, then I think it would be a more clear cut example of when you may have to report, may have to um, use a duty to warn. If the person says, yes, my partner knows my status and has chosen to be with me anyway, it gets more complicated. So I don't want to, I really want to hesitate or am hesitating about giving a clear answer on that. I would say look to any obvious kinds of cues like have they reported it to their partner? Maybe you said this in the question and I'm not remembering. But, you know, it's a great question. I would really encourage in a situation like that that you work through the details of what's going on with your supervisor, agency director, whoever might be appropriate, and figure out from your perspective what you think would be in the best interest of both parties. That's a lousy answer, I know, but without knowing detail, it's hard to advise on that. I want to be careful not to go against any policy that you might have. So sorry if that's not a great answer.
Thanks, Bob. It looks like that's all the questions we have for now. Or sorry, one more just came in from Carol. Are there any differences to what you have presented so far related to ethics and tribal authorities or laws that govern tribal lands?
I'm sorry. Could you say that one more time? I'm sorry.
Mm-hmm. Yep. Are there any differences to what you have presented so far related to ethics and tribal authorities or laws that govern tribal lands?
Well, uh, tribes have autonomy in that they're sovereign nations, so there are differences, obviously, in how ethical kinds of decisions would be made because of cultural differences in tribal law. Um, the federal law, privacy law, would apply to tribal communities as well. Beyond that, though, other kinds of ethical decision making would be up to the tribal community to flesh out. That's my answer to that. I think.
Perfect. Thanks so much, Bob. I think we can probably go on from here for now.
Okay. I hope those answers weren't too vague. The only thing I'll focus on a bit here is transference and countertransference. Um, you're imposing on the client. God, I get these mixed up. I apologize, guys. Um, one is imposing your beliefs on the client, and the other is where the client sees you as a representation of somebody else they know. I believe that's the way to define those. Somebody else has a better definition of that. Just if you would type it in so I can not confuse everybody to death. The point of this, in terms of boundary issues, is to be aware of these things, so that in your interaction with the client, you're sort of counterbalancing yourself here and not reacting in a way that you might be inclined to if you know these things are occurring, right? So recognizing that transference and countertransference are occurring. I should have looked these up before the webinar to make sure I had the definitions correct. So I'll wait for one of you to give me a better definition. I'll come back to it. We talked about this stuff a little bit. I think some of these things are pretty obvious. You certainly don't want to have a relationship with a client that you're working with. You certainly don't want to pay somebody that's your client to work for you. Some agencies have different policies around when a clinician could date a client or have a relationship with a client. Some say never. That would be my advice. Some say a year, 2 years, something of that nature. So you can check your own policies around that. But my advice would be to never, ever have a personal relationship with a client. Reason being primarily is that there's a power differential that exists in any kind of relationship like that that can be damaging to the client. They will always see you as somebody of authority or somebody that's in a position of power. Whether they behave that way or not, that's how they will view you. And better to stay away from that. I know some people that have not done that, and it's worked out okay. But my advice is to avoid. Talked about duty to warn. Child abuse is a reportable offense, and sexual misconduct of a therapist is a reportable offense to ethics boards or licensing boards. So I always say use your supervisor. I mean that. That's what they're for. They're a mirror sometimes. They're a sounding board. They're a source of advice. Can help you think through complicated situations like the HIV/AIDS example that Susan, I believe, provided, and help just keep you within the rails in terms of which direction to go. I think if you always operate from the standpoint that I did what I did because I believed it was in the best interest of my client, and you didn't knowingly violate any laws, usually you're pretty safe. But again, it gets more complicated than that. So use your supervisor. This is just a summary, so let me see if I forgot anything. The one point there, let's see, 1, 2, 3, fourth bullet down, your ethics can greatly impact the quality of client care and the image of the profession. One thing we don't talk about a lot and probably should do more of is that how we represent ourselves not only determines the quality of client care, but it determines the quality of our profession. How we conduct ourselves as professionals directly impacts how other people view our profession. Addiction treatment right now, sorry about that. Addiction treatment right now is undergoing a transformation that it hasn't seen before. In that the profession itself, which has evolved separately from the rest of healthcare, is now being asked to integrate with the rest of healthcare. Right or wrong, the image that many healthcare professionals outside of addiction care have of us is that we're less qualified, that we're somehow less well trained, that our profession is really paraprofessionals, not licensed and educated, and all of those things that other areas of healthcare value very much. So, like I said, whether that's true or not, we have to present ourselves in such a way, right now especially, and redefine ourselves in such a way that the rest of healthcare acknowledges not just that we're competent, not just that we're ethical and well trained, but that we are equal to or even more so well trained in client care for this population, that we offer something to the rest of healthcare that's valuable and that's professional, um, that involves professional codes of conduct and training. And we almost have to go above and beyond making that point. And the reason I say that is because it's critical in terms of making integration happen in a meaningful way, and it's important for uh, building our workforce and bringing people into the profession. We have to set an example as professionals for other students, for other people who are interested in this career to look at and say, this is really a high quality and meaningful profession to go into. Like I said, I think it is, but I have to be aware of the perceptions of what we do and how to improve those perceptions so that we can make integration happen, maintain our own identity in terms of what we do as professionals, and also learn to work well with others. The problems that exist around that primarily come from the fact that we have not been accustomed to doing that. We have not been accustomed to working with other areas of healthcare. And we feel, I think, the addictions treatment field feels as though we can only operate within a very narrow scope of practice. So part of what we'll have to do going forward is look at ways in which we broaden that scope of practice enough to include doing assessments on people that go beyond just their addiction, just their substance use histories. And while we don't want to operate outside of a scope of practice, we do want to be able to make recommendations to other areas of healthcare when we recognize areas of a person's health are affected. So if they have physical complications, they have mental health complications, that we as professionals feel comfortable reaching out to other areas of healthcare, working within an integrated team, and contribute to person health. I hope that makes sense, but I feel a need to really express that to people in our profession currently and people that are thinking about entering the profession, because we really have to make an effort here to find ways to collaborate with the rest of healthcare. That's the direction it's going. I think the train has left the station. Um, the recent presidential election will have some impact on how that occurs, but I think it will occur, and we will be considered eventually in the near future a part of healthcare, not a separate standalone specific kind of treatment. We will be a part of healthcare, and I think that's a good thing. And I think it will challenge us in many ways that we haven't been challenged before as professionals. I am done, folks. So if you have any additional questions, I'll take them right now and try and answer them.
Thank you so much, Bob. We do already have a question from Marilyn. She asks, can a counselor stay in contact with the previous client from a previous substance abuse program where they were employed?
Well, I would go back to your agency's policies around that. I would think that since addiction is a chronic and ongoing illness for many people, that any sort of professional kinds of contact are helpful. I think that's the real reason that peer support has taken off, is because there's an ongoing sort of relationship with the client, a professional relationship that offers support, that offers hope, and all of those things that are important to somebody in recovery. So I would say, as long as it's within a professional kind of set of circumstances, that it would be okay to do that. But you have to check your agency's policies around that. I think this is a healthcare condition. So if somebody had heart disease and you knew about it and they went to another doctor to get help, you knew them, I don't know that it would be a bad thing to check in with them and say, how are things going? And is there anything I can do to help? Just wanted to check in with you. Personally, I think that's just a human kind of response to anyone with an illness, a chronic illness or otherwise. So I think it might be okay, but you have to see what your program or agency says about that.
Wonderful. I don't see any other questions right now. If please submit them now if you have one. Um, just want to remind everyone that we will be sending out emails to everyone who registered. We are recording this so you can review it at a later date, and we also have handouts of the PowerPoint so you can study those and use those for your continued edification. And yes, if questions come up for you that didn't strike you today, feel free to get in touch. We would be happy to respond. Um, we also, as we close out, we will be directing you to our evaluation. So please follow through to that. If it pops up on your should pop up in your browser. If not, don't be alarmed. We will also send a link out in our follow-up email. So we would love to hear some feedback on today's webinar. So please, if you wouldn't mind, take a few minutes and let us know what you thought. And yeah, it doesn't look like we have any other questions. I did want to mention because Bob had discussed earlier in the session the need to take care of yourself as a provider. Our next session in our behavioral health series is actually on that very topic, and that's taking place a week from today. So we'll watch for our email to go out with the registration. I should be sending that out later today. So we would love to have you join us on that topic on healing the healer and the importance of taking care of yourself as a provider. With that, Bob, did you have anything else you wanted to share before we close?
No, not really. I just wanted to say thank you and to say that the questions you did ask were very, very good ones. If you, like Kate said, if you would like better answers than what I gave, we will try and respond to you later.
Yes, absolutely. Thank you so much. Thanks for your participation and for being with us today. And yeah, thanks again, Bob, for your insight and sharing your experience with us. Yeah, we have a lot to learn from you, so I always appreciate it. And with that, I will close us out. And thanks again, and hope to see you next time.